It is now my pleasure to introduce the speaker of this opening international lecture. Professor Eric Hollander is joining us virtually from New York. Thanks, Eric, for being with us today. Eric Hollander is a professor of psychiatry at the Albert Einstein College of Medicine in New York. He's also the director of the Autism and OCD Spectrum Project at the Psychiatric Research Institute of Montefiore Einstein, and he's also the editor-in-chief of the Journal of Psychiatric Research. I have been collaborating with Professor Hollander for 20 years, having been a postdoc in his group. And among his numerous affiliations and awards, I'll only mention his unique expertise in the field of OCD, anxiety, impulsive and compulsive disorders, as well as autism spectrum disorders, in which he is certainly one of the most active and cited researchers worldwide. Professor Hollander will talk about next generation treatment in obsessive compulsive and related disorders. Over to you, Eric. Thanks for being here.
Okay, well, thank you, Professor Dell'Osso. It's been a great 20 years collaborating with you, and I'm appreciative of you inviting me to this very distinguished conference. I'm going to be talking about some novel or next generation treatments, and I'm going to share my slides with you. Okay, perfect. So I'm going to talk about some unique and very novel treatments for obsessive compulsive disorder and other obsessive compulsive related or spectrum disorders. I'm going to focus on esketamine, cannabidivarin or CBDV, intranasal oxytocin, and I'll also talk a little about the use of the new GLP-1 agonists like Wegovy and Zepbound as well. And as Bernardo mentioned, I'm at Albert Einstein College of Medicine and Montefiore Medical Center in New York City. And I've had the good fortune to work with Bernardo in the International College of Obsessive Compulsive Spectrum Disorders as well. These studies were funded by grants from the Orphan Products Division of the Food and Drug Administration to develop new treatments for rare disorders, the Department of Defense to develop new treatments for autism, and these studies also involved collaborations with Roche and with Jazz and GW Pharma. In particular, I'd like to highlight collaborations with Casara Ferretti. And also, we've had several research fellows from Bernardo's group as well, and they've been an outstanding help in these studies as well. In particular, I'm going to be focusing on these next generation treatments, intranasal esketamine, cannabinoids, and in particular cannabidivarin, the intranasal oxytocin, and the GLP-1 agonists. These other treatments also can be considered next generation treatments, and we've been involved in some studies of psychedelic psychotherapy with psilocybin, LSD, and with MDMA in disorders such as general anxiety disorder, depression, and autism. The glutamatergic agents are also frequently used now when the standard treatments aren't successful. Sigma-1 agents are also being studied, and of course, neuromodulation is playing an important role in these treatment-resistant conditions. So here's a brief listing of the obsessive-compulsive related disorders. Today I'm going to be talking about some studies in obsessive-compulsive disorder, in Prader-Willi syndrome, which is a rare homogeneous model of obsessive compulsive related disorders, and an autism spectrum disorder. But the group of OC related disorders include a broad range of conditions, including things like hoarding, grooming disorders, body dysmorphic disorder, eating disorders, and somatoform disorders. So let's start with some initial work with intranasal esketamine in patients with obsessive compulsive disorder. All of the patients in this study, in order to get into this study, had to have comorbid treatment-resistant depression, In the US, intranasal esketamine is approved for the treatment of resistant depression, but patients with other comorbid conditions like OCD can be included. And briefly, esketamine is a non-competitive NMDA receptor antagonist. We use the S enantiomer of the racemic form of ketamine, which is an NMDA ionotropic glutamate receptor antagonist. And this is a nasal spray. It's approved for treatment-resistant depression. Patients have to come into a prescriber's office or a clinic that's licensed to administer esketamine. And generally, they come in and stay for 2 hours with each nasal administration. During that time, we observe them for their blood pressure, for example, for sedation, and then we can discharge them. And it's been noted that esketamine has a rapid reduction in depressive symptoms and can also be effective for reducing suicidal ideation in those patients. And the general strategy is they come in twice a week for 4 weeks, then they come in once a week for 4 weeks, and then depending on how they're doing, we may enter them into maintenance treatment, which might be anywhere from once a week up to once a month, but generally once every 2 or 3 weeks. So in this study, we treated 23 patients who had obsessive compulsive disorder that was treatment resistant and had comorbid treatment resistant major depression. Out of the 23 patients, 16 were male, 7 were female, and out of those 23 patients, 14 of them were rated as being treatment responders based on a CGI improvement or of 1 very much improved or 2 much improved, and 9 patients were treatment non-responders. On average, they were 37 years of age. The patients were white. On average, they were treated with 24 different administrations of intranasal esketamine. And the vast majority, 22 out of 23, received the highest approved dose, which was 84 milligrams in the intranasal spray of esketamine. And then based on the clinician global improvement scale, those patients who received a 1, which was very much improved, or a 2, which was much improved, were considered responders. Of the 23 subjects, 14 out of 23 were responders in terms of their obsessive compulsive symptoms. So that was 61% of the group. 39% of the groups were considered treatment non-responders. So they either were minimally improved, unchanged, or they were worse. We also looked at their CGI improvement severity ratings at baseline and at endpoint. And the scores range from moderate severity to very severe. And then at endpoint, they were had minimal symptoms up to a score of 6. The patients in green were the 16 responders, and the lines that are dark green were that there were multiple patients who started out with this score and ended with this score. So we see some distribution with about 60% of patients getting an improvement overall in their global severity scores on OCD in this population. Now, what were the clinical symptoms that improved with the Spravato or the esketamine? Well, first of all, there was a marked reduction in rumination symptoms and an improvement in flexible thinking. And the patients who improved also had an increase in motivated and goal-directed behaviors. If we look at the specific types of obsessions and compulsions that improved, we see improvement in the checking rituals and washing rituals, just so compulsions, the religious obsessions or intrusive thoughts, trichotillomania or hair pulling, the doubting obsessions, obsessive fear of brain damage, improvement in body dysmorphic disorder symptoms, and improvement in hypochondriacal symptoms. We see one patient who had a gambling disorder that had marked improvement. We see improvement in superstitious thinking and inability to touch objects. Now, what about treatment maintenance in these patients? Well, for those individuals who had a significant improvement and tolerated the treatment well, and actually all of the patients tolerated the treatment well, they were entered into maintenance treatment. And the maintenance treatment ranged from every 2 weeks to every 4 weeks. On average, patients were coming in every 3 weeks for maintenance treatment, often for an extended period of time, meaning that they were getting significant continued benefit, they were tolerating it well, and that they insisted on continuing the treatment in order to get continued benefit. The next sort of next-gen treatment that I'm going to be talking about are the cannabinoids. We got interested in this area because of our interest in patients with autism spectrum disorder. Many of these individuals have explosive behaviors, so they can have meltdowns with aggression and self-injury, often triggered when there's a deviation in their expectation in the environment that results in discomfort, and then they have to explode in order to reduce the discomfort. So there are many families in the United States who are receiving medical marijuana for their children in order to reduce the explosive episodes. And usually they were administering the medical marijuana on a PRN or as needed basis. Well, we know that there are both endocannabinoids and plant-based cannabinoids. The endocannabinoids in the brain include anandamide, AEA, and 2-arachidonoglycerol, or 2-AG. These endocannabinoids bind to the CB1 receptors in the brain and the CB2 receptors in the immune system. The plant-based or phytocannabinoids include THC, which is the active ingredient that gets you high. THC does bind to the CB1 and CB2 receptors, but also CBD, cannabidiol, and CBDV, cannabidivarin. These agents and over 200 other compounds do not bind to the CB1 receptors in the brain or the CB2 receptors in the immune system. They bind to other receptors. So THC binds to the CB1, CB2 receptors, and through different molecular pathways, including MAPK and the mTOR pathway, result in all kinds of second messenger changes that exert the effects and have some role in modulating glutamate and GABA function. CBDV doesn't bind to the CB1 and 2 receptors, but primarily it binds to this GPR55 receptor. And this GPR55 receptor is in the cell membrane. And so plant-based cannabinoids like CBDV have effects opposite to THC because they don't bind to the CB1 receptor. They have, the CBDV is unique compared to CBD in that it has a 6-fold greater binding to this GPR55 receptor. And in fact, what happens is CBDV binds to a lipid in the brain called LPI, lysophosphatidylinositol. It pulls that lipid off the GPR55 receptor, therefore activating the receptor, and it modulates glutamate and GABA balance within the synapse. In the clinical trial that we conducted, we went up to doses of 800 milligrams per day of CBDV compared to placebo. And we did this study in children with Prader-Willi syndrome, this rare condition that can be a model for obsessive compulsive disorder. And Prader-Willi syndrome occurs in 1 in 15,000 patients. The father's imprinted genes on chromosome 15 are not expressed, but these individuals have mild intellectual disability. They have low muscle tone. They have severe temper tantrums and mild cognitive deficits, but they have a range of compulsive features. First, they have compulsive eating or hyperphagia, and they can become very obese if you don't restrict their food intake. They have a lot of repetitive and compulsive behaviors, skin picking, and when there's a deviation, let's say in the mealtime, they have these severe temper tantrums. So we administered the CBDV up to 800 milligrams a day compared to placebo in children with Prader-Willi syndrome, and we measured their compulsive behaviors on the Montefiore-Einstein rigidity scale that looks at total severity of rigidity and repetitive behaviors. Behavioral rigidity, a combination of behavioral and cognitive rigidity, and how much protest or how much explosive behavior they have. In all of these subscales on the MERS, we saw a very large drop in severity with the CBDV compared to the placebo. So there was less behavioral rigidity, cognitive rigidity, protest, and total compulsivity. In addition to the MERS scale, we saw a significant difference on the Y-box obsessive compulsive scale and on the repetitive behavior scale revised. So on multiple different scales that tap into rigidity and repetitive behaviors, we're getting a reduction with CBDV compared to placebo in these patients. This turned out to be a very large effect size. Usually we consider a large effect size a Cohen D of 0.8, and we see for behavioral rigidity or protest or total compulsivity much larger Cohen's D scores. So we're seeing a very large effect in the symptom domain in this population. The next compound that we studied was oxytocin, which is a peptide that's synthesized in the hypothalamus. It's released peripherally, and it's involved in labor and delivery and lactation. Centrally, it plays a role in social cognition, so social memories and trust. Vasopressin also is a similar peptide that has similar effects, but perhaps reciprocal. But it also has anti-inflammation effects and anti-obesity effects. Previously, we had administered oxytocin with an intravenous infusion in high-functioning young adults with autism and saw a reduction in the lower order self-stimulatory types of repetitive behaviors in high-functioning autism. We wanted to study oxytocin because there's reduced oxytocin receptors. Mice who have reduced oxytocin receptors tend to overeat, and when they're administered oxytocin, their food intake and body weight improves. And we did studies both in Prader-Willi syndrome and in autism spectrum disorder. I'm going to show you the results in children with autism, 32 patients who received either 24 international units of oxytocin by nasal spray or placebo. And here we see a comparison of oxytocin versus placebo on all of the Montefiore-Einstein rigidity scales: behavioral rigidity, cognitive rigidity, protest, total rigidity, and total compulsivity. Here we see actually very little difference between oxytocin and placebo on these repetitive behaviors. We also looked at the repetitive behavior scale revised and also compared oxytocin and placebo, and also found very little difference on all of these things like stereotypy, self-injurious behavior, craving for sameness, rituals. So in contrast with intranasal oxytocin, we did not see a reduction in repetitive behaviors in children with autism on the similar scales, the MERS scale and the RBSR scale. So we're getting different results with these different compounds. And then finally, I wanted to talk a little about the GLP-1 agonists. Again, Ozempic or Wegovy or Zepbound, Mounjaro, are all GLP-1 agonists. These compounds are modeled after this enzyme that's made in the gut, but readily crosses the blood-brain barrier, regulates food intake, provides neuroprotection, decreases inflammation, enhances synaptic plasticity, amplifies signal transduction, and potentiates cognitive function. So it has a range of different physiologic effects. Now, it turns out that there are GLP-1 receptors all over the brain, and these GLP-1 receptors regulate lots of different processes: glucose homeostasis, appetite control, body weight management. They regulate metabolism. They slow down gastric peristalsis. They're involved in lipid metabolism, cardiovascular regulation, neurological functioning, and glycogen synthesis in the liver and in the skeletal muscle. And these GLP-1 receptors are 7 transmembrane structures. They're expressed throughout the nervous system in the midbrain, like the hypothalamus, the hindbrain, and mesolimbic or reward system regions like the ventral tegmental area, the nucleus accumbens, and the amygdala. So they have this very interesting distribution in the brain. And now these GLP-1 drugs are being studied for a range of different conditions, initially for type 2 diabetes and then obesity. So they have FDA indications. But now they've been studied in addictive disorders, so nicotine use, alcohol use, cocaine use, and opioid use. In impulse-controlled disorders such as binge eating disorder, compulsive shopping, and compulsive sexual behavior. There's a lot of interest now in studying cognitive disorders like Alzheimer's or dementing disorders, and cognitive difficulties relating to type 2 diabetes, and the relationship between type 2 diabetes and dementing disorders. There's also interest in studying this in obsessive compulsive related disorders such as Prader-Willi syndrome, autism spectrum disorder, and then other conditions like bulimia, for example, kidney disease, and cardiovascular disease as well. Now, one dramatic effect that the GLP-1 agonists have on the mesocortical limbic circuitry, which is involved in motivational responses, is to rapidly turn down food noise and to turn down thoughts or noise or craving with other substances as well. So it decreases food cue reactivity or persistent thoughts of food, ruminations about food, thinking about next meals, for example. The interest in the addictive disorders comes from the idea that you have these GLP-1 receptors in these brain regions that are involved in reward and addiction, including the mesolimbic dopamine system, the VTA, and the nucleus accumbens, and of course dopamine projections from the VTA to the nucleus accumbens, and effects in the nucleus solitary tract as well. Now, there's also an interest in studying the GLP-1 drugs for cognition as well. And so the GLP-1 drugs have effects on oxidative stress, neuronal apoptosis. They enhance neurogenesis and neuroplasticity. They decrease neuroinflammation. They decrease the aggregation of beta amyloid and tau, increase insulin signaling, decrease neurotoxicity. So they can have neuroprotective effects And as a result, they can have effects on cognition and memory, and the anti-inflammatory effects can affect glial inflammation, for example, and again, neurogenesis and synaptic plasticity. We've planned a large study now in young adults with Prader-Willi syndrome in collaboration with the Foundation for Prader-Willi Research and patient-centered outcome research initiatives. So these are going to be Prader-Willi syndrome adults who are either overweight and obese or are overweight and obese but have comorbid other weight-related type conditions. They're going to be studied for 18 months in a comparative effectiveness trial comparing the GLP-1 receptor agonist semaglutide and tirzepatide versus a dietary intervention, which is a low carbohydrate diet. And as an outcome, we're looking at hyperphagia, and then we're looking at weight-related effects, such as percent change in weight, percent change in age and sex-adjusted BMI, and markers of metabolism like hemoglobin A1C. So we've been talking a little about next generation treatments for obsessive compulsive related disorders. There's been, lots of work for 30 years on the use of selective serotonin reuptake inhibitors in cognitive behavior therapy. There's been some more recent work with glutamatergic agents as well. Despite these, effective treatments, there are still many patients who remain treatment resistant. And so we have to look for other types of compounds that may be helpful in this treatment-resistant population. And I've talked about 4 different studies, one with esketamine, showing that about 60% of treatment-resistant OCD patients who have comorbid resistant depression are responders to Spravato. This is open-label data, and it needs further replication, but is intriguing. And we also find that these patients continue to maintain their benefits over time, but often need continued maintenance treatment. Next, we looked at one of the cannabinoids that don't work through the CB1 receptor, cannabidivarin, which has a large effect on the GPR55 receptor, and found a very large effect on reducing repetitive behaviors in Prader-Willi syndrome individuals across a number of different measures. Third, we looked at the use of intranasal oxytocin in a group of patients both with Prader-Willi syndrome and also with autism, and found that intranasal oxytocin did not reduce the repetitive behaviors, either in the autism population or in the Prader-Willi population. And then finally, we talked about some novel approaches with these new compounds like the GLP-1 agonists, which appear promising across a range of compulsive and impulsive and addictive disorders, but even other conditions involving cognitive impairment, for example. And clearly this needs further study, but lots of studies are going on. Well, what are some of the mechanisms that are in common across these different novel treatments? One is the idea that these different treatments may decrease neuroinflammation and improve this excitation-inhibition imbalance in the cortex, which plays an important role in OCD. And we've also utilized an approach focusing on rare or orphan disorders to try to reduce genetic heterogeneity. And that makes it easier to find drug versus placebo differences, which can sort of magnify the effect on repetitive behaviors in these rare conditions as well. So I'd like to thank Professor Del Osso again for inviting me. I'd like to congratulate the organizers of this conference, and thank you so much for having me here.